Hypertension and dyslipidemia. Hypertension is also known as high blood pressure. It is known as the silent killer because there are just no symptoms with it unless the person is in a hypertensive crisis. And then they can experience a severe headache, chest pain, dizziness, and shortness of breath. This condition is serious if not treated, but many people with it may not feel symptoms at all. The only way to diagnose hypertension is to check your blood pressure regularly, and there's a few different stages to it. So 120 to 129 over less than 80 is just considered elevated, and then stage 1 is considered 130 to 139 over 80 to 89. Stage 2 is considered 140 or higher over 90 or higher, and then the hypertensive crisis with the symptoms would be 180 or higher over 120 or higher. And then there's also 2 categories you can group hypertension into. The first one being primary. It's also called essential, and that usually comes from an identified source, and that makes up 85 to 95% of all human hypertension cases. And then secondary comes from an identified underlying condition. And then dyslipidemia is a metabolic syndrome, and it refers to abnormal levels of lipids in the bloodstream. This can cause inflammation, oxidative stress, cardiovascular disease, and other metabolic dysfunctions by other mechanisms. There's 2 pathways to this one too. It can be caused by genetics or lifestyle choices that can lead to a higher likelihood of this occurring. So obesity could be a factor playing into it. There's also primary and secondary dyslipidemia. Primary is caused by the genetics, and then secondary is by the lifestyle choices. To test for this, which is the only way to diagnose, you look for lipids like LDL, HDL, triglycerides, and total cholesterol. And if numbers are higher than the standard, then we can diagnose dyslipidemia. LDL should be higher than 100 milligrams, and then HDL should be higher for 40 milligrams for men and 50 for women. Triglycerides should be less than 150 milligrams, and then total cholesterol should be less than 200. And then this one also doesn't have any symptoms, but it does put you at a higher risk for developing cardiovascular disease. Play this video.
Hello, I'm Dr. Elizabeth Mary Thomas, the internal nursing specialist at Astor Clinic, Sports City. I'm here to have a quick word with you about dyslipidemia or hyperlipidemia. What is this? This means that the cholesterol levels or triglyceride levels, the fatty levels, in our blood are elevated. Why is this important? It is important because this being elevated for many years or even decades can affect the blood vessels and lead to complications such as stroke or heart attack. Who should get their cholesterol levels checked? Adults above the age of 30 years can get their cholesterol levels checked every year or 2, but it's especially important to those who have a family history of high cholesterol levels, stroke, or heart attack. What do you do if the cholesterol levels are elevated? Don't worry, the first thing is not tablets. First, we will try to fix the lifestyle measures, such as making sure the diet is correct and making sure you get enough exercise. And only if that doesn't work will we proceed to tablets. I hope this has cleared up about hyperlipidemia for you. Wishing you good health. Thank you.
So for the fit comparison for dyslipidemia, the frequency is greater than or equal to 5 days per week. Intensity is 40 to 75%, which is moderate to vigorous. The time is 30 to 60 minutes per day to promote or maintain weight loss, and 50 to 60 minutes or more of daily exercise is recommended. For the type, you want prolonged rhythmic activities using large muscle groups like walking, cycling, or swimming, and resistance training 2 to 3 days per week, flexibility greater than or equal to 2 to 3 days per week. So for dyslipidemia, the main difference from the healthy population is that you want greater to or equal to 5 days per week instead of just 3 to 5. And then you want 30 to 60 minutes per day instead of 30 for weight loss. For individuals with hypertension, the frequency is greater than or equal to 5 to 7 days per week. Intensity is moderate. Time is greater than or equal to 30 minutes a day of continuous or accumulated exercise. Type is prolonged rhythmic activities using large muscle groups. Resistance training, you want greater than or equal to 2 to 3 days per week with moderate intensity. And flexibility is greater than or equal to 2 to 3 days per week. So the main difference with individuals with hypertension is that you want to go 5 to 7 days per week instead of 3 to 5.
Special considerations for individuals with hypertension, exercise testing and vigorous exercise training in those with mild to high risk for cardiac complications should be medically supervised. Beta blockers may affect thermoregulatory function. Beta blockers may increase the predisposition to hypoglycemia. In these situations, individuals need to be educated and take precautions to avoid these situations. Beta blockers reduce the submaximal and maximal exercise capacity, especially in individuals with myocardial ischemia. In these situations, peak exercise heart rate achieved during the stress test should be used to determine exercise training intensity. If peak heart rate is not available, use RPE. Medications such as alpha blockers, calcium channel blockers, and vasodilators may lead to an excessive sudden drop in blood pressure with exercise. This effect is independent of age, and in these cases, an extended cool-down period should be utilized. The blood pressure lowering effects of aerobic exercise are immediate, and then if an individual with hypertension begins to experience ischemia with exercise, the situation should be treated the same as cardiovascular disease ischemia protocols. Special considerations for individuals with dyslipidemia. Individuals taking certain medications such as statins and fibric acid may report extreme muscle soreness and weakness. And here's a video.
A new study out today confirms what millions of people taking statins have been complaining about for years, and it may offer a solution. Sharika Duncan has more on this.
Peggy O'Connor, who suffered a heart attack after years of battling high cholesterol, had complained to her doctor about statins she was taking, drugs that can lower bad cholesterol.
When I started on the statin, I started having muscle spasms.
Claims like that were initially dismissed by some in the medical community. Dr. Stephen Nissen is the lead researcher of the Cleveland Clinic study.
We've confirmed that this is a problem that's real, and we have given them an alternative.
Dr. Nissen says problems including muscle pain and weakness affect up to 10% of people on statins, or 3 to 4 million Americans. The study looked at more than 500 patients who reported side effects and are considered statin intolerant. The patients in the study were given a statin or a sugar pill. About 42% who took a statin experienced muscle pain or weakness. The second part of the study involved testing non-statin cholesterol-lowering drugs. One was an oral drug, the other injectable. Both worked, however, the injectable had better results.
Patients that got one of the new injectable cholesterol-lowering drugs had a 52 to 54% reduction in the levels of their bad cholesterol.
What are the costs per year when talking about the injectable non-statin drugs?
It is about $14,000 a year, so they are quite expensive.
The cost for statins is a few $100s per year.
Dr. Nissen estimates about 36 million people in this country rely on statins. So far, 2 injectable non-statins have been approved by the FDA. Jack?
Sharika Duncan, thank you.
Alright, here we have exercise risk. I'd estimate the quantity of evidence for the relationship between hypertension and adverse responses to exercise at 4 out of 5. There is strong clinical and physiological evidence supporting this connection, though individual risk varies based on hypertension severity and exercise type. Exaggerated blood pressure response. Hypertensive individuals often experience a disproportionately high rise in blood pressure during exercise, increasing cardiovascular strain, endothelial dysfunction. Impaired nitric oxide production leads to reduced vasodilation, limiting blood flow, regulation, and increasing vascular resistance. Left ventricular hypertrophy. Chronic hypertension can cause structural heart changes, raising the risk of arrhythmias and ischemic events during exercise. Autonomic dysfunction. Heightened sympathetic activity and reduced parasympathetic tone can increase heart rate variability and cardiac stress. Increased risk of acute cardiovascular events. Elevated baseline arterial pressure raises the risk of myocardial infarction, stroke, or sudden cardiac arrest with high intensity exertion. While moderate intensity exercise is generally beneficial, individuals with severe hypertension should be medically screened before engaging in vigorous activity. And the estimated risk level is 3 out of 5, and endothelial dysfunction or dyslipidemia contributes to atherosclerosis, impairing blood flow and increasing cardiovascular strain during exercise. Inflammatory response, chronic low-grade inflammation from dyslipidemia can elevate oxidative stress, reducing exercise tolerance and increasing muscle fatigue. And impaired lipid metabolism, altered lipid utilization may lead to reduced energy efficiency, increasing the risk of early fatigue and delayed recovery. And an increased risk of arrhythmias. Elevated cholesterol can affect cardiac ion channels, making the heart more susceptible to exercise-induced arrhythmias. And exaggerated blood pressure response. Dyslipidemia is linked to arterial stiffness, which may lead to excessive rise in blood pressure during exercise, increasing cardiovascular risk. While exercise remains beneficial for dyslipidemic individuals, careful monitoring is advised, particularly for those with additional cardiovascular risk factors. That's our
Yep. 1 second.